So thank you, Amy, and thank you, Dr. Lambs, for joining us. Our guest today is Dr. Laura Lambs from Michigan, who originally is from Auburn, Alabama, and received a BS degree from Davidson College, followed by an MD degree from Vanderbilt University in 1992. From there, she completed a pathology residency, followed by a surgical pathology fellowship at Vanderbilt, and then she joined the faculty at the University of Arkansas for Medical Sciences, Little Rock, in 1998, where she spent about 20 years, rising to the rank of professor. While at the UAMS, she also served as the vice chair for academic affairs until February 2017. Currently, she is the Godfrey Stobbe Professor of Gastrointestinal Pathology at the University of Michigan, Pathology Department. Dr. Lambs is a renowned academic pathologist and educator, and a leader in the fields of gastrointestinal, hepatic, and infectious disease pathology. She has received multiple teaching awards and has been invited as a visiting professor or course faculty at more than 60 institutions throughout the country and the world. She has authored numerous papers and abstracts throughout the country, many abstracts, especially in an area of gastrointestinal pathology and infectious diseases of liver and the GI tract. She is the co-author or author of several major pathology textbooks, including the surgical pathology of the GI system, including diagnostic pathology and diagnostic pathology, normal histology, then diagnostic pathology, GI endoscopic correlation. She has contributed numerous book chapters to texts, including Holtz and Goldblum's surgical pathology of the GI tract, liver, biliary tract, and pancreas, which is regarded as the most widely used GI pathology in the world. She's also one of the 4 editors of the 11th edition of Rosai and Ackerman Surgical Pathology that I'm sure almost everyone in pathology has owned one copy at one time or the other. Until March of 2017, she served as the chair of the United States and Canadian Academy of Pathology Education Committee. And right now, she is the current USCA president-elect. Dr. Lamb lives in Ann Arbor with her husband, Paul Ward. She is active in animal welfare efforts, and she serves on the board and as president of the Central Arkansas Rescue Effort for Animals. They have a cute pet named Henry, whom actually they rescued. And among many other skills, Dr. Lambs is an avid knitter. She's a good cook, and she's also a substitute yoga instructor. So I can go on, but I'm sure you all get the point. So what an excellent time for us to be hosting a world-renowned specialist in infectious diseases of liver and GI tract. It's a great honor this morning to have Laura here with us today. She'll be speaking on the topic, Emerging Infections, Historical Perspectives, Precipitating Factors, and Pathologic Diagnosis. So join me in welcoming Laura Lambs. Laura.
Good morning, and thank you for that very kind introduction. I'm so glad to be with you virtually, if not in person. I'm a big fan of the University of Minnesota and of Minneapolis. So I've given versions of this talk several times because I'm interested in infectious diseases and also in emerging infections, but I have never given this talk during a pandemic. So it seems strangely appropriate today to be doing so. Disclosures, my dogs, especially Henry, will feature prominently in this lecture. I have too many shoes and I eat too much chocolate. And during the pandemic, my shoe use has gone down, but my chocolate consumption has gone up, which may not be that healthy. And I do get some book royalties from Elsevier. So there are a couple of definitions of what an emerging infectious disease is. And one is a totally new or previously unrecognized organism. Depending on when you came into pathology, you might remember when HIV was first described. You might remember when hantavirus was first described. Those of us who were in training in the 80s and 90s remember when the so-called non-A, non-B hepatitis was then characterized as hepatitis C. And more recently, we've had SARS and now COVID-19. So one definition, and I think the most publicly not acknowledged one, of the most popular one, is a totally new or previously unrecognized organism. Another definition, though, which is interesting to those of us in GI pathology, is a previously recognized organism that is then more recently identified as a true pathogen. And of course, the greatest example in GI pathology is H. pylori. We saw it on slides for decades before we realized what it did and the role it played in the pathogenesis of ulcers and gastric cancer. A more recent example is Aeromonas species. Aeromonas was originally described as a pathogen of sea animals like turtles, but then was found to be a human pathogen much later. You acquire it from swimming in certain lakes in warm water, and it causes a gastroenteritis. And then finally, and many of the things we're going to talk about today fall under this category, an emerging infectious disease can be a known pathogen that undergoes epidemiologic changes, whether we understand them or not, such as an increased incidence or a different geographic range. And examples of that are basidiobulomycosis, which we'll talk about more in a minute in terms of its expanding geography, schistosomiasis, which is changing in distribution as they build dams in Asia and Egypt and Africa, creating new opportunities for snails to colonize bodies of water. Lyme disease distribution is changing in the Northeast because reforestation is getting the ticks and the deer closer to the homes where people can be bitten. And cryptosporidium and other coccidians, which we're seeing more and more of with flooding and public water processing plants that can't handle the volume of water and aren't set to filter for cryptosporidium. So a number of factors contribute to emerging infectious diseases. Antibiotic resistance, a huge problem. Antifungal resistance is also becoming a problem. New or permissive environments. I think all of us have a better insight into that than we ever did with COVID, looking at how transportation, travel, and migration contribute to the spread of disease. Urbanization can also do that by preventing new exposure to pathogens or vectors. And then if you're interested in food science and the fact that despite the local food movement, a lot of our food is shipped from far, far away, contaminated food or water source can affect people miles and miles away from the point of contamination. Another thing to think about is new or vulnerable host populations, whether it's immunodeficiency, genetic factors, such as with COVID, they think certain blood groups are more vulnerable. All of us, I think, when we think of immunocompromised, automatically go to the big three of patients with AIDS, patients on chemotherapy, or patients who've undergone transplants. But I would encourage you to expand that definition as you look at cases and think also of very elderly patients, very young children who under the age of 2 or 3 when their immune systems are not fully formed, pertinent to GI pathology, people who have chronic inflammatory bowel disease or other immune diseases who are on chronic immunomodulator therapy such as the new biologics or steroids. And then finally, diabetic patients, patients who've had splenectomies, chronic alcoholics, any malnourished or chronically debilitated patient may not have a fully functioning immune system. So when we think about immunocompromise, I would just encourage you to think beyond that big three of AIDS, chemotherapy, or transplant. So in my other life, I do a fair amount of work in patient safety and risk management. And so we think about these risk matrices when we're thinking about, we have limited resources and what problems we're trying to solve. So in terms of clinical medicine, a lot of times where we want to put our resources are learning about things that have a high probability of happening and a significant risk of harm to the patient if they do happen. And so, for example, perforated appendix. Our surgical colleagues, our radiology colleagues, our ED colleagues spend a lot of time thinking about how to diagnose perforated appendices because it's going to happen, happens frequently, and if you miss it, it can cause considerable harm to the patient. An example of something that has probably a high likelihood of happening, but low risk of harm to the patient might be something like a mild adverse drug reaction, a rash, or a mild nausea or diarrhea. If you miss that diagnosis, you don't want to miss it, but the risk of harm to the patient is probably fairly minimal. What I think COVID has shown us all, and people have been talking about for years, these are the really hard things to prepare for because they have a very low risk of happening. If they do happen, the impact is going to be huge. And I think we've all learned that in the past 6 to 8 weeks. So if we think about this risk probability chart, which I started thinking about because when I travel around and talk about infectious diseases, one of the things people usually say to me is, well, I'm not going to learn about infectious diseases because I'm never going to see them. And I would argue, and hopefully will convince you by the end of this time, that that's not true and convince you why you should learn about them. So in terms of anatomic pathology, we spend a lot of time looking for things that in the appropriate background we're trained to recognize. So most of us are probably pretty well trained not to miss, for example, a squamous cell carcinoma in a smoker. We're primed to look for it in smokers. We don't want to miss it. That would be terrible for the patient, but that's a pretty straightforward situation. On the high likelihood of happening but low impact range, an H. pylori infection. We're all going to miss an H. pylori infection at some point in our lifetime if we sign out stomach biopsies. Do we want to miss it? No, but if we do, it's probably not going to be that harmful to the patient. And then finally, in our low likelihood of happening but high risk category, many of the cases for discussion today fall there because they're rare and they're unusual. But if you miss them, it has a very significant harm effect on the patient. And I will use cases and examples from the literature to hopefully illustrate that for you. So one of the things I got interested in when preparing for this lecture was the volcano that erupted in Iceland in 2010. I spent a long time trying to learn to pronounce this volcano's name. I even went to Google and did the pronunciation lessons, and I failed miserably. So I can't say it, but I think most of you are probably aware of the volcano. And the ash from that eruption caused airline flights to be canceled. People expected it to wreak havoc on travel and the number of people who would be stranded in Iceland or unable to get to Iceland. But what nobody predicted was the economic havoc because so many people used Iceland as a stopping off point as they flew goods from the US to Europe and from Europe to the US and around the world. And Iceland was a pretty common stop and refuel point. And so nobody anticipated that. So people who've studied lessons from the volcano, which I think are really applicable to emerging diseases and this pandemic, are that low probability, high impact events are areas of vulnerability. We've all been living that for the past 6 to 8 weeks. But this also applies to diagnostic anatomic pathology in that things that are unlikely to happen but have a very high impact on the patient are big areas of vulnerability for us. But we can learn from lessons learned in other sectors of science and technology, such as the volcano. So people who've studied the volcano came up with a couple of pointers that I want to share with you. And I think we've all learned recently that rare things are rare, but neither non-existent or impossible, which means we have to prepare ourselves for things that it may be hard to even conceive of, such as a pandemic or some of the cases I'm going to show you today. I think we also have to think about the fact that local things don't remain local very much anymore. Things that we used to rarely see because they happen in other parts of the world, we may see commonly because of travel, immigration, especially of either our people or food sources. We might also apply this to strange patterns of metastasis or strange patterns of vasculitis. And another thing the volcano studiers pointed out is that the individual has to be just as, if not more so, invested in a good outcome than the government or as any supervising body. We as individual pathologists, individual trainees, have to be really invested in learning these things because we're the ones who are going to actually see the cases. At the bottom of this slide is the paper that talks about everything they learned from the volcano and the ash cloud. But some of the final lessons, I think, are really applicable to us. Collect all the information you can about events and communicate with others. We're already seeing that with COVID, with a number of case repositories for COVID cases. That, again, individuals have to be as invested in the outcome as the government or your department leadership. We all need to be invested. We should be aware of best practices. Today, that will be ancillary ways to diagnose things. And then finally, build up a library of observations that can be drawn on when preparing for similar things in the future. And for us, I think this is the literature. The more we can contribute to the literature, the more we have a library of observations that we can draw on in the future. So with that introduction, We'll move on to the case presentation section of our lecture. I'd also like to point out that many of the things we're going to talk about today and many emerging infections can't be cultured. And so it's very helpful if we can recognize those patterns of disease in tissue on an H&E slide or with special stains. Other helpful history in all of these cases includes travel, what people have eaten, what they do for a living, what animals they've been exposed to, if they've had a tick bite, sexual practices, and of course, as we talked about earlier, immune status. So here's our first case. This patient was a 45-year-old man. All of these cases are from my personal practice, consult practice, so they happen in real life. This gentleman was a migrant worker employed in Arizona, and he presented with severe abdominal pain. He was imaged, and he had a large near-obstructing colonic and pericolonic mass that radiographically looked like colon cancer. And because he was about to obstruct, they went ahead and resected him. They did a biopsy before resection that looked like this, a lot of necrotic tissue with a very impressive eosinophil infiltrate. And then once the resection came out, it was granulomatous. And again, you see that necrosis. And I'll draw your attention here to these areas. And here's another slide showing the granulomas. You can see the palisading histiocytes here, can still appreciate the eosinophils, but then these strange pink structures here with clear centers and this pink protein around them, which will end up being a very valuable clue to diagnosis. Here that is at higher power, where you can really appreciate that pink protein around the optically clear organism. And here's another example. So this protein turns out to be Splendor Hepley protein, which we're mostly used to seeing in GYN pathology around actinomyces colonies. Here's a GMS stain because this is a fungus. And you see these fungi here with optically clear centers. They're really irregular, kind of blob-shaped fungi, and they have very few septa. Here's another example showing them at higher power. You can appreciate how irregular they are and the septa. And many of them have this form called the cellophane ball form because it looks like you wadded up a piece of plastic before you threw it away. And that's another morphologic tip-off to this organism. So this is Basidiobulbomycosis. The organism is Basidiobolus ranarum, which is closely related to mucor, and it's a worldwide soil saprophyte. And the interesting thing about this fungus is all of the original, we've known about this organism for decades. And it was described in Saudi Arabia and Africa in the desert where it caused a dermal subcutaneous infection. But recently, there's an emerging cohort of cases in the US, in Arizona. So we've got a different geography, but in our US cohort of cases in the desert Southwest, they're all GI. And no one knows why both the site of infection and the geography has changed. We have not figured that out yet, but it is a very interesting epidemiological change. The GI cases, in this case, often mimic malignancy, and they do respond to antifungal therapy, but there are some pretty significant complications in the literature. Vulnerable populations similar to mucor, its cousin, are kids, presumably because children eat dirt, along with pica syndrome, peptic ulcer disease because it has a portal of entry, diabetics because of their metabolic issues, PPI use, especially ranitidine, and living in an endemic area in our country, the desert Southwest. So in this case study from 2014, they had a gentleman from Mali who presented with abdominal pain. They thought that he had TB and treated him for TB, and then he died of sepsis. And at autopsy, Basidiobolus ranarum was identified by PCR. And when they went back and looked at the original case, they found the pathogens, and they had been misled by the granulomas. So they point out that this infection is rare and presented considerable difficulty because they'd never seen it before. And this case report calls attention to those features. It is similar to mucor, which is in the GI tract, more often caused by the colonization of ulcers, and has pathologic features that are more similar to Aspergillus. Here's an example of that. Here's an ulcer biopsy from a diabetic patient, and in the acute inflammatory exudate, you can see all of these organisms in the surface. And if we look at higher power, you can appreciate the ribbon-like large forms of mucor that we expect to see, along with the optically clear centers, but we can also appreciate how many more organisms there are than we typically see in Basidio-bolus, and we can also appreciate the branching, which we don't see in Basidio-bolus, highlighted here on a GMS stain. Most often in surgical pathology, of course, we see mucor as a sinonasal infection and an emergency in bone marrow transplant patients. Here's an example of that, where we have a blood vessel in the middle. It's been pretty much replaced by mucor. So if we compare the two, mucor is angioinvasive, has many more organisms, does not have that Splendor-Hepley protein, does not have the eosinophils, and is more likely to occur in diabetics, whereas Basidio-bolus is not angioinvasive, as you saw, has many fewer organisms, does have the eosinophils, does have the Splendor-Hepley phenomena, has more defined granulomas, and is in a different population of farm workers and desert dwellers and people who work outside typically. So in summary, this organism resembles mucor, but is not angioinvasive and has a very, very different tissue reaction, which is almost pathognomonic. We should suspect it in patients from endemic areas with paracolonic masses. The patients are often not immune compromised, and mucor in the sinonasal tract, in contrast, remains a medical emergency. And there's my dog Alice looking for soil saprophytes. She's very good at it. My second case is a 25-year-old Chinese exchange student who came to Arkansas to study, and he went to the emergency room with diarrhea and lower GI bleeding. On CT scan, he had a thickened colon and some liver lesions, and they first biopsied the colon, which on endoscopy just looked terrible, as you can appreciate from these biopsy sections. He has no normal mucosa left, this very significant mixed inflammatory infiltrate, which when you first start looking at it, you see these macrophages and you can't really tell what's in them. And I spent a lot of time wondering, is it junk? Is it really an organism? What's going on here? And here you can see them at higher power. So I sent this to a friend of mine. Here's the GMS stain, who's a really good microbiologist. And still at this point, I thought these were organisms, but I wasn't entirely sure. And then he found a bunch that looked like this, where you can appreciate that they look a lot more like an organism. Some people refer to this as the pill capsule sign, because you've got a tiny little septum there that almost looks like a Tylenol capsule. Meanwhile, they aspirated this gentleman's liver lesions, and the same organisms, as you can see here on right Giemsa stain, were seen in his liver. So he turned out to have Penicillium marneffei, which is now called Talaromyces marneffei, which is a dimorphic fungus that's endemic in Southeast Asia and Far Eastern Asia. The other cases I've seen were from people who'd served in the military in Asia. It is considered now to be an AIDS-defining illness in endemic areas, and it most commonly involves the lungs and liver, followed by GI tract as the third most common site. And although it is endemic in Asia, we're seeing more of it in other countries because of travel and immigration, or people have a low-grade infection for years and they become immunocompromised and it flares. Typically, it has a granulomatous response. As we saw in the GMS, the yeast forms are septate, often with that pill capsule morphology, and they look, in terms of size, very similar to histoplasmosis, but they don't bud. These people need months of antifungal therapy, and if they're immunocompromised, it can disseminate rapidly and kill the patient very rapidly. In this study from 2015, they looked at a non-endemic area in China, but an area that was very close to endemic areas. They had 47 AIDS-associated patients who had this infection, and talked about how difficult it was to make the diagnosis in an area where it's not endemic, just because people didn't think about it. And they say, which makes sense, two independent predictors for early mortality were delayed diagnosis and no treatment with antifungals. And they had a very high mortality rate. And again, this was a country where they see this, but a very large country and an area where it was not endemic. And so I think that's a challenge for us here, where we're going to see this because of travel, but we're not used to it. Here's another under oil photograph showing the pill capsule and the lack of budding, in contrast to histo. So characteristics of yeast and tissue sections, I won't spend much time on this, but you'll have it in the recording. Histoplasma is perhaps most similar to Talaromyces, different distribution, and Talaromyces doesn't bud. Cryptococcus has the narrow-based buds and is very pleomorphic. Blastomyces is much larger with broad-based buds, and Candida is more likely to be extracellular and does not form hyphae. In contrast, here's a case of colonic histoplasmosis. I think you can appreciate on this biopsy the infiltrating histiocyte population. And when you do the GMS stain, you can see the similarly sized histo that have rare buds and don't have that central septum. Here's another example of histo illustrating one of the best known features on H&E, which is that little pale halo that forms around each organism. Here's another example under oil immersion showing the budding histoplasmosis on GMS stain. So this was a case that I saw of a patient who came in because of abdominal pain. And here's a duodenum, and I'll draw your attention to the fact that the duodenum is fairly unremarkable except for this giant fungus ball here. You can see the fungus ball in higher power on the left, and if I were there with you, I would ask you to guess what kind of fungus it is, and you would not be able to guess because this is a portobello mushroom. So one thing to be aware of is that when you're seeing GI biopsies, if the patient recently ate mushrooms, you may see false contamination with the mushroom. And my friend Bobby Pritt at the Mayo actually took several types of mushrooms and processed them to see what they looked like under glass. And so that's just a nice artifact to recognize. So T. marneffei, to summarize, is one of the most common infectious diseases among Asian AIDS patients. We're seeing more in this country due to travel and immigration, and it needs to be distinguished from other small intracellular fungi so that therapy can be instituted. And now Alice and Zoe are claiming over the fact that it's very irritating when for years organisms have one name and then they just rename it and you have to learn a new difficult name all over again. Our third case was a 46-year-old HIV positive gentleman who presented with fever and weight loss. And the CT scan showed mesenteric lymphadenopathy, which was biopsied. It looked like this. Here's a lymph node capsule. Here is a granuloma at the edge. And here is a spindle cell process that had virtually replaced the lymph node. Here it is at higher power, showing the fascicles of spindle cells with elongated nuclei. And when we performed histiocyte markers, they were all histiocytes. And then when we did AFB stains, this turned out to be Mycobacteria. When it was typed, it was MAI. So this is a pseudotumor secondary to non-tubercular Mycobacteria, which of course are present all over the place. Interestingly, they're increasing in patients without AIDS. And in one recent study of patients with chronic pulmonary disease, immunosuppressive medications, and comorbid diseases, about 25% of patients with MAI had no known risk factors. So we're seeing this in many different situations. The atypical or non-tubercular Mycobacteria are all over the place in soil, in milk, in food, in water. There are all sorts of there are 4 major groups with all sorts of species that we won't talk about today, but MAI is the most commonly encountered in pathology specimens. So as you see here, a chart of all the different body sites and all the different types of mycobacterial infection, which are expanding all the time. MAI affects the most sites and is the most common, but really any of these can affect a number of sites in the body. One of the really interesting things and challenging things about MAI is that depending on the site of infection and the immune status of the host, a number of histologic patterns can be produced, which I'll show you. So this is the one we all learned about when we were junior residents, the small bowel biopsy with the histiocyte infiltrate that contains innumerable mycobacteria on Zeal-Nielsen stain. Here's a liver showing that same type of foamy infiltrate, an AIDS patient, so very little attendant inflammation, but a significant portal histiocyte infiltrate. This gentleman was immune compromised. Was not immune compromised. He was immune competent. He was an outdoor worker who developed abdominal pain and ileal thickening. They at first thought he had Crohn's disease, but he had MAI. And here you can see this nicely formed granuloma because he had a competent immune system. Here's another AIDS patient and a liver infection showing these little microgranulomas as well as fibrin ring granulomas, which can also occur with MAI infection. In this cytology case report, which illustrates the importance of recognizing the spindle cell pseudotumor, they biopsied a patient with a lung pseudotumor and noted all of this cellular atypia, which they interpreted as a neoplasm. So the patient underwent surgical resection. And when they got the specimen out, it also revealed granulomas in addition to the spindle cell process, and they did cultures and it grew Mycobacterium chelonia. So this patient underwent unnecessary surgery because of the fact that they didn't recognize that this could have been an infectious process. The primary things in the differential diagnosis are TB and other atypical mycobacteria. One thing I'll draw your attention to is that these AFB-associated pseudotumors will mark with desmin, actin, and keratin. So if you don't think about the infectious process, you may well go down the path of this being a sarcomatoid carcinoma or a sarcoma, because these will mark. Another caveat is a GMS stain, which we commonly think of course, for fungi. A GMS will mark any rapidly dividing bacteria. So this is the same AFB case that we saw a few minutes ago, stained with GMS, which is highlighting all of the mycobacteria. So you have to look at the morphology as well as the GMS positivity. So the therapy varies by species, which is why there's often pressure from our clinical colleagues to do PCR if we didn't get a culture. Unfortunately, in some of these cases, there's so few organisms, even if you see them on your special stain, there may not be enough to do PCR. But often we're pressured to do that regardless because they're trying to put forward the most appropriate therapy, especially in this age of microbial resistance. So all three dogs watching for emerging infectious diseases, they can come from anywhere. Unfortunately, they did not recognize COVID very early. Our fourth example is a 40-year-old gentleman with chronic watery diarrhea and an unintentional 25-pound weight loss. He had an essentially normal colonoscopy and EGD, but they took biopsies anyway. And in the small bowel, I'll draw your attention to the brush border where you can start to see these little blue beads or beach balls. And at higher power, you can see them even better right here at the luminal surface. And you can also appreciate that there's a few eosinophils, but not a lot of increased inflammation, which can make this diagnosis difficult. And at 60x, you can see that they're right under the surface cytoplasm. Here's his colon biopsy, showing the same thing at the border of the colon epithelium. And this is cryptosporidium. We're seeing a lot of this when we look at episodes of flooding, such as in 2015 when they had the big floods in Texas, there was cyclospora outbreak. We've seen cryptosporidiosis in Indiana in 2011 when the fire hydrant water was contaminated and there was a big fire and all the people who came into contact with the hydrant water got cryptosporidium. And then a year earlier in Sweden, they had a big contamination with the public water supply. So the coccidians, of course, are the parasites that cause diarrhea in both immunocompromised and immunocompetent patients, but are a particular clinical problem in immune-compromised people. And they're easily transmitted through food, water, fecal-oral spread, not hard to get. As seen here, the endoscopic exam is usually normal. These are hard to diagnose based on stool studies because they require special stains. And so typically we rely on a mucosal biopsy to make the diagnosis. This is one of the earliest studies of infectious diseases in the GI tract of AIDS patients. And I think the take-home message here is that when they first looked at this 33-patient cohort and did all this workup, rectal biopsies, stool samples, xylose and Schilling tests, which we don't do anymore for malabsorption, the first round, they couldn't find anything. And this is before we really recognized the organisms that happen in AIDS patients, especially the coccidians, which we weren't used to looking for. Then when we went back, when this group of people, not me, went back, after knowing more about the coccidians, they found a lot more of them, and they found Giardia, Campylobacter, and CMV, as well as a bunch of other things. So on the first round, none of these patients had a diagnosis, but on the second round, once we knew more about what happens with AIDS patients and the gut, they were able to find a diagnosis in almost 70% of patients. So our coccidians, which now Microsporidia, have been reclassified as fungi, and Cryptosporidia have been reclassified as a different type of parasite. We still group them together for teaching purposes because they look similar. And so again, I won't spend a lot of time on this chart, but you'll have it in your recording. Microsporidia is the hardest to diagnose because it just causes this tiny little vacuolization of the supernuclear cytoplasm, and you really need a special stain to diagnose it, such as this tissue gram stain, brown bread, or this modified trichrome, which nicely highlights the spores in the cytoplasm. Cyclospora is a little bit easier to diagnose, although it still can be very subtle. You can see it here in the round form. It also has a banana-shaped form. And one of the tip-offs to both Cyclospora and Cystoisospora is the nuclear disarray at the surface. On high power, you can see both the round form and the banana-shaped form, and they typically, again, similar to Cystoisospora, have this vacuole that surrounds them. It can be a tip-off at medium power that's what you're dealing with. And there's another example of that vacuole. Cystoisospora is the largest. You can see it much more easily on H&E. It has also either the large round or large banana-shaped forms surrounded by the vacuole. And again, here you can see the nuclear disarray. Here's another example in the gallbladder that nicely illustrates that surrounding vacuole. So almost all other intracellular organisms are within macrophages and not within the epithelium. So that's one big tip-off when you see an intracellular organism that it might be a coccidian. The other things in terms of size that can mimic this are Leishmania, toxoplasmosis, and the small fungi that we already talked about. Here's an example of Leishmania in the liver on a Giemsa stain, which you can appreciate is within macrophages. So to summarize, infection by coccidians is not limited to immunocompromised patients, and mucosal biopsy is often the best way to make the diagnosis. Stool studies are only helpful with special stains, and importantly for us as surgical pathologists, they have minimal associated tissue reaction, so you want to remember to look for them. And here's Henry celebrating that he shouldn't have had that last beer. The final case I'll talk about today is this one, which is one of my favorite cases of all time. This lady was a nurse at the university, or she was in Little Rock when I was at the University of Arkansas, and she had a reported history of Crohn's disease, although in retrospect, when we dug around for history, this had never been proven with a tissue diagnosis. And she had an apparent flare, and they put her on steroids, and she didn't improve. In fact, she got worse, and she started bleeding. So they did a right colectomy, and right during the surgery, she decompensated. They couldn't get her extubated. They had to leave her intubated and take her to the unit where she very rapidly developed pneumonia. So the specimen looked like this. And remember that she did have a reported, at least, history of Crohn's disease. So here you see a lot of architectural distortion. You've got inflammation extending into the submucosa. So, okay, this could be Crohn's, maybe. And there's a higher power view of the architectural distortion. But then as we started to look around, you start to see these little guys within the epithelium. And there's more of them, and this one has an eosinophilic reaction. And then at the area of perforation, you can see fecal contamination here, but similar organisms here, and you can see their little pointed tails. And they were within the lymphatics, as you can appreciate right here in the bowel wall. And a lot of little granulomas with eosinophils. Here's another example of a cross-section of one of these in a lymphatic. And here's the outside of the bowel, the serosa, with a worm. Here's a lymph node, which has a similar worm in it. And finally, the reason they couldn't get her extubated, this is her sputum, and she had the organisms in her sputum. So this was Strongyloidiasis, which is a soil nematode with a worldwide distribution, but it's particularly endemic in places with warm climates like the Southeast USA. And they can live subclinically for up to 30 years, but steroids causes the conversion of a chronic low-grade disease into a fulminant infection. And that's what happened in this case. This woman was going along. She'd probably had infection for a long time. And when she got that steroid bolus because of her what people believe to be a Crohn's flare, she converted into a fulminant, life-threatening infection, although she did recover. Here's a study from Human Pathology, 2009, that illustrates this problem. In this case series, the misdiagnosis of strongyloides for IBD and treatment with steroids had an extremely high 40% mortality rate. In this series, they were more mistaken for ulcerative colitis, but this paper illustrates the features of strongyloides that can be mistaken for IBD, including skip lesions, distal attenuation of the disease, the eosinophils, and frequent involvement of the submucosa. So that's a nice paper underscoring this diagnostic problem. Patients can range from being asymptomatic to a wide range of symptoms when they are symptomatic, but the most feared complication is the steroid-associated fulminant infection, as we saw in this case. It can be found anywhere in the GI tract. It may have a minimal inflammatory reaction or a significant one, as we saw in our test case. The pointed tails are a really useful feature, and these are not actually within the lumen. They're in between the crypt epithelial cells, as nicely illustrated in this stomach biopsy. Here's another slide that shows that from our first case. You can see it within the borders of the epithelial cells. And here's another example of that stomach biopsy that really illustrates nicely the pointed tail. They can have an eosinophilic infiltrate, as you see here, or a primarily neutrophilic one. This particular patient was actually a teenager who got put on a steroid pack for his asthma, and he developed strongyloides. One thing we're seeing more and more of, and I can't tell you why, and I don't think anybody knows why, is, as I showed you in the previous example, the most widely known location is in between the epithelial cells, but we're seeing more and more invasion of the lamina propria. And when the worms are in cross-section, all you may see is this little spotted cross-section of the organism, and the key to its being there is this little nodule of eosinophils. Here's another example with the worm in, I don't know why that wants to stick, the worm in longitudinal section. You can see it there, surrounded by eosinophils. So now when I see a cluster of eosinophils or a nodule on a biopsy, I'll get levels to make sure that I'm not seeing an invasive strongyloides. So this morphology, the location in either the epithelium or the lamina propria and the worms with that morphology is almost pathognomonic. The only other thing that looks that way is Talaromyces, which is in the Philippines. Schistosomiasis produces eggs. You only rarely see the worms. Anaerobius or pinworm is too big, and it's in the lumen, not between the epithelial cells. And anisakiasis, or the sushi worm, is gigantic. You can see it with the naked eye, and it's typically in the stomach and associated with a history of sushi. So this is one of the few parasite things that we can diagnose really with an H&E. There's almost always a history of steroid use, and in fact, some cancer centers are now doing reflex testing for serologies for strongyloides if steroids are going to be included in the patient's chemotherapy regimen, because they don't want to cause that fulminant infection. I hope I've convinced you that this infection can mimic IBD, and if you see pockets of eosinophils on a biopsy, you want to consider recuts to look for the organism. Occasionally, stool exam for ONP or serologies are helpful. More often, the serologies are helpful for screening, not diagnosis. But the best way to diagnose this is an anatomic pathology slide. So in closing, I hope that I've convinced you that emerging pathogens are very important and often under-recognized, and that these are things that we used to think of as just happening in other countries, that we're never going to see it here. But I hope I've convinced you that due to travel and immigration and just the way that disease spreads, that these are important things that you may well encounter in your own practice, and that a good history of travel, food intake, animal exposure, other risk factors can be really critical to making the diagnosis. In the GI tract, emerging infections are a clinically significant problem, particularly in immunocompromised patients, although certainly not limited to them. And immunocompromised can mean a lot of things in addition to AIDS or transplant or chemotherapy. There are a number of cultures and molecular studies that can help us confirm the diagnosis, but in these types of cases, a morphology can be your first clue to directing therapy, especially in a very sick patient. Even if you have to, for example, send something for tubercular or non-tubercular identification, you can at least help the clinicians get to the right starting point if they need to start therapy. So there's Henry in closing who wants to know where our snacks are. And miraculously, I think that we are on time. And so I will ask Amy and Deli to help me take questions.
Thank you very much. If anybody has a question, please use your chat feature to submit it or raise your hand and I will introduce.
And Amy, are you all going to read me the chat?
Yes, ma'am.
Okay.
Okay, Deli.
Okay, so I guess I'll get things kicked off. So thank you very much, Laura. That was quite impressive and a bit scary too. For many of us who look at GI biopsies, and sometimes a lot of volume comes across your desk and you're just skipping through a lot of them. So, but that is very, very important to remind us of some of the things that we may be missing and the things that we really, really don't want to miss. So one of the questions that one of the residents sent across while you were speaking is what they can do with some of these images. You know, is it possible to, what do you call it, to get some of them? So they are trying to get a Twitter account. And these are some of the kind of things that they want to be discussing and training about, just to show that you gave this lecture and to be able to share it across. So how much freedom, and I think many of them are online now to hear directly from you.
So how much freedom they have to use the images?
Yes, on Twitter.
First, tell me what that is.
Oh,
So
Twitter. I'm sorry, I misunderstood you. Yeah. Oh, on Twitter. I would prefer that they not be on Twitter, but I would be happy, and I'll tell you why in a second. I'd be happy. I mean, you all have the lecture recorded, and I would be happy to give people a copy of the lecture for their educational use.
Okay.
Or even the pictures for their use if they credit me. But what I don't like about Twitter is it just tends to start arguments about what things are or aren't. And I'm not on Twitter, so I don't see it. But I mean, obviously I can't stop anybody, but I'd rather give people the images and the lecture for their own educational use rather than Twitter. But I understand that that's what people do these days.
Yeah, thank you. At least I needed to ask that one. And I think one of them might probably be in touch with you at the end of the lecture. So
okay. I'm easy to find.
Anybody else?
Dr. LLamps, I have a question regarding COVID. This is Emil Recila. I work in the surgical pathology. So regarding COVID-19 infection, at one point, especially early on, there was some discussion about COVID-19 infecting the small bowel. So do you have any insight, maybe not from the COVID-19 because there were so few autopsies done for COVID-19, but maybe from the SARS, the past coronaviruses, what type of cells are infected and what type of pathology we should look for?
So I haven't seen any SARS cases. In terms of COVID, we actually, because we're so close to Detroit, we've done a number of autopsies here, and we're in the process of trying to get some bowel specimens. The one surgical case that we have seen from a COVID patient was ischemic bowel because, as you know, they get thrombotic phenomenon associated with the infection. So the one case we've seen just showed ischemic bowel, but we and a lot of other people are in the process of trying to collect cases to look at what it looks like in the bowel. I don't think we know that yet. My colleagues who are looking at lung and visceral organs, originally they thought there might be inclusions that are visible, and now they don't think there are, just viral cytopathic effect. But there are people all over the country who are collecting specimens from both bowel and liver to study, but I don't think we have a good handle yet on what COVID actually does to those organs. And one of the challenging things is these people, a lot of them either have thrombotic problems, or they're on ECMO, and so they have vascular issues related to being on ECMO. So it's going to be a challenge to sort out what are the therapeutic effects from what the virus actually does. But that work's ongoing, and unfortunately, I never saw a SARS GI case when SARS happened.
Thank you.
Okay, can I go on? So one other question is concerning the role of CBC as a pointer to some of these parasitic infections that you described. So when we talk about parasite, we always talk of peripheral eosinophilia. So has this been, very useful or helpful when you look at some of these cases in leading you to suspect what to look for just by looking at the CBC?
In my experience, it's really, really variable. It's just like if you're looking at the non-infectious disorder, idiopathic eosinophilic gastroenteritis, 3/4 of them have an elevated eosinophil count, but a good 25% of them don't. So for whatever reason, some of these people have elevated eosinophil counts and others don't, and I don't think we know why. And of course, there's also regional variability across the country in eosinophils. There's seasonal variability. So personally, I have not found it to be that helpful.
Okay.
I find seeing them in tissue to be more helpful than seeing them in the blood.
Anybody
Okay.
else? If you have a question at this time, you can simply unmute yourself and speak.
Okay. Well, it looks like if we have no more questions coming in, I want to thank Dr. LLamps once again. And one of the things that I left out in my introduction is Dr. LLamps' emphatic refusal to accept any kind of honorarium that usually we give to some of our speakers, in recognition of the difficult times that most academic departments are undergoing. So many, many thanks to you. And I look forward to a time when we'll be able to see you here physically and we'll be able to have more of a human-to-human interaction rather than Zoom-to-Zoom interaction. Thank you very much, and have a lovely day.
Oh, thank you. My pleasure. And again, if anybody has additional questions that they don't want to ask out loud, or if they want images or anything, please feel free to contact me. Deli and Amy know exactly how to find me, so I'll be happy to talk to you by email.
Thank you.
Thank
Sounds
you.
good.
You guys
Thank
stay
you,
safe. Have a
everyone.
great day.